I work with neurology. I work with functional neurologists. We work with kids with encephalopathies and tics and all of these other things, and we see positive changes after we do these procedures. Are we changing nervous system pathways? Are we going from more sympathetic to parasympathetic, or increasing vagal tone? Or are we changing this with breathing, or changing it? We're trying to kind of get a more of an elucidation on what we're doing. But everybody's always like, how do you diagnose? How do you classify? And how do you do this stuff? There's no one right answer, and we try to standardize these things. When we're trying to evaluate babies and children, we try not to do it with them sitting in front of us. Most of us, in the United States anyway, have them lying down, where it's either their head is in your lap or you're coming from behind them, and we kind of look from behind. And some of the simplest things, or things that we do, actually had a very well-known tongue-tied doc in my office last week from Israel, Eyal Batzer, who does a lot of research as well. He still comes from the front. We joke around, it's just the Israeli way that they do it there, but the United States, we all try to come from behind. So when we're evaluating these kids, I keep it simple. And I'm not talking about just anatomic location of where these things, but kind of really how tight they are. So one of the simple tests we'll do for looking at a lip is we lift the lip all the way up to the nose, coming from behind. If there's a point of tension, and these things, the gum tissue blanches, we call it a tie versus a normal frenulum. We like to see, or what we classify, quote unquote, normal, is that frenulum is maybe stretchy, softer in appearance. If you're rubbing your finger from side to side, does it feel tense and tight, or is it kind of just soft and mushy? There was a very well-known pediatrician actually in San Diego, who actually was also an IBCLC, Jim Murphy, who developed a classification system. And his simple classification system was kind of rubbing his finger from side to side under the tongue. And if he felt, either what he called a fence or a fence post, kind of, obstructing his easy glide from side to side, he termed that as a tie. He kind of got into more, defined classifications. And we find some of the classifications we really kind of do just to help us more with our research and publications versus, how it's affecting somebody functionally. One of the most widely used classification systems, for babies, and we kind of converted a little bit up to older kids and adults, is Larry Kotlow's classification. Larry's a very famous tongue-tie pioneer, laser pioneer up in Albany, who was one of the grandfathers of our specialty here, and that's a published thing. Now the thing with that is his classification system only talks about anatomy and anatomic location of these restrictions. Doesn't talk about function, or what we term mild, moderate, severe. And there's so many other classification systems out there at this point. Like I said, I don't really even get involved in mild, moderate, severe anymore. I say, is it there or not? What's going on with their function? So you talk about the Brazil validated protocols. It's out there in the literature. I can give it to people if anybody wants it. We're trying to come up with a more functional definition. Dr. Zaghi and Dr. Yoon out in Stanford in California doing a lot of work in this area at this point, looking at tongue range of motion, where these things are attaching. And one of the other myths that we try to dispel among professionals, if you can stick your tongue out, you're okay. Elevation is really one of the biggest keys that we're looking for, when we talk about restriction of anatomy and structure and function as well. And, looking at the functional definitions, elevation, is really kind of one of the key things we're looking at here. We get into the other areas of ties. Lip ties are pretty common, one of the more easy things for people to kind of notice or see. And the different classification systems out there, there's really only one, it's Kotlow's lip tie classification system. And that really talks about the point of the frenulum attachment going from up high all the way down low in between the teeth. If it's a baby, it's really kind of looking at, this slide here where it goes from up high to the right, maybe down to the gums or wrapping onto the roof of the mouth. From a feeding standpoint or an infant feeding standpoint, we find that the lip tie prevents the flanging of the lip fully. around the nipple of the breast or the bottle. We find in a lot of cases they don't have the ability to form a very good seal that can break their latching. We find that a lot of babies not only leak around that, but maybe they start sucking in more air. I'll talk about some of the research we've done and colleagues around the world have looked at with reflux and whatnot and swallowing air. These affect teeth and growth and development. A lot of times, people always talk about David Letterman or Michael Strahan with their big gaps between the teeth. I don't know if it's specifically from a lip tie, but lip ties are more, of a predisposition for forming diastems or gaps between teeth. So we get them coming in from orthodontists a lot of times, and there's been kind of a change in paradigm shift of timing of treatment of these things. We used to wait, we used to put braces on, close spaces, and then take care of these. We've been finding along the years, and we're trying to get numbers up to publish, is that we've been taking care of these in younger kids and seeing, these spaces and leveling and aligning and closing of spaces of dental arches and airways, before orthodontics. So we're trying to kind of be proactive and interceptive. The cheek ties or buccal ties, which you can see kind of on that slide up on the right-hand side, the little webs on the sides. If you feel up around with your tongue, you really shouldn't feel any bands, and if you do, you probably have a tie there. And that doesn't mean they have a problem, but I see them coming in from not only the functional feeding, speech, and other functional people I work with, but a lot of times they come in from dentists, orthodontists, gum docs, because they're pulling on gums and causing dental problems. Maybe some gum recession or gaps between teeth. We see a lot of kids coming in because not only are they having speech and feeding problems, a dentist will send them because they're struggling to brush the teeth. It hurts them. They can't get the toothbrush in there. Every time they're trying to get a toothbrush in there, those bands are holding it, things are so tight. Not only is the toothbrush rubbing up against there, but it hurts. And it's like, I can't get, brush my kid. It takes 3 people to brush my kid's teeth. So there's all these little pieces of a puzzle that we look at. And then again, we're just one person as part of a team. There were the other slides talk about, a large amount of people, and many times, sometimes it's a huge number of specialties that we have to work with to help our, patients and our families move through. And what I tell my families, or when I'm educating other colleagues, I say, we're not just treating that child, we're not just treating that airway, we're treating the whole family. This affects everybody. You heard Sydney's story, it affected their whole family. This affects everybody. There's crying, there's sleepless nights, there's so much anxiety that goes in. What's wrong? I don't know what's wrong. Something's wrong. Everybody keeps telling me everything's all right, but I know something's wrong. So we just have to listen. And that's the one thing I've learned through my career. And it's unusual for me because my colleagues as surgeons don't typically listen and tend to be very arrogant and say, I know better. I don't. And I keep questioning myself. Like, I might be missing something here. I need help. I need to reach out to people that may know more than me or know something else that I don't know. And that's one of the things I've learned and I keep learning to do is to kind of reach out for that. When we talk about treatment, the treatment from my standpoint is one of the easier things I do. It's just kind of managing all these other things that's more difficult. Timing of treatment, and I'm not going to get into the details about that, that's a big question mark. I really depend on my functional therapist to kind of get these kids prepped and ready to go. It's not always feasible. And there's a lot of other, factors that come into play, whether it's the schedules of the families, monetary issues, so many little pieces of the puzzle. And we kind of have to say, do I just leave this child with a very obvious tie, or do we treat it and try to do our best? And that's a question, and I don't have the right answers, and I'm learning along the way. And, we make mistakes, things happen. We're just trying to make those mistakes with minimal risk, and that's the biggest thing that we look at. I'm not going to get into the use of lasers versus non-lasers. I've been using lasers, in July, it's going to be 22 years of using CO2 lasers for this. I've used every laser, and I keep coming back to CO2. I just find it more gentle on the tissues. In my hands, it tends to work well. I have colleagues, my mentor trained in scissors and trained me in scissors, and I went to laser, and that's how I do it. But I don't disparage people who use scissors as long as they do it the right way. we look at these things, and this is just a nice little case example of a child, that was just kind of being missed and missed and missed. And everybody's saying, oh, we're not going to treat the lip tie until, we're going to close the gap with braces first after they're, much older, when the adult teeth come in. And we see so many of these cases coming in through the office, and it's, we're trying to get the data collated, and I have other colleagues around the country doing the same as well, and we're seeing changes. When we release soft tissues and we start to get better soft tissue function, we start to see changes in dental arch and facial growth development, ultimately airways. So we're looking at, helping these kids not only, eat better, breathe better, sleep better, but, their facial appearance starts to change and the orthodontic things start to change for them. And this is a pretty clear-cut case that was actually the child of a dental hygienist, who was like, I know, this is not sitting right. I'm looking at this frenulum, and everybody's telling me not to touch it. The dentist is saying don't touch it. The pediatrician's saying don't touch it. And she's like taking the bull by the horns, like, I'm advocating for my child, and we're going to do this. It's like, what's the risk? The biggest risk I find when we're talking about a lip tie release, maybe it's going to grow back. We're not near any major, anatomy as far as neurovascular anatomy or other things, so we can, look at that. And I've not even seen an infection in the thousands of cases I've done with these procedures. It's reported in the literature, but when you actually look at the true risk of the surgical procedure when it's done the right way, we see things, and I get complications coming in from other providers, not saying it didn't do it the right way, but we see it, but I just haven't seen it in my own practice. But we try to keep it simple. I want to just jump to some research here, because we can get into cases all day here. But what are we doing to change things? What are we doing to give what everybody's asking for as far as evidence? And it's a struggle. Several years ago, I published a paper on what we termed aerophagia-induced reflux. Over the years of doing this, and we had seen it in the past 10, 15 years, there was a a significant number of infants coming in on reflux medications. And these medications, and if you look in the literature, you look in the journal Pediatrics, these medications can have potential serious side effects. And that could be issues with bone breakage. We're not sure if the use or overuse of these medications has led to an increase in allergies, in children, with potentially changing gut biome. Just by happenstance, as we were doing all these procedures for breastfeeding and potential bottle feeding, many of the parents that we were seeing said, what did you do? My child or my baby's reflux is gone.